Parietal cells are acid-producing cells of the stomach that secrete acid in response to three main stimuli. 1. Acetylcholine release from the vagus nerve. 2. Gastrin release from antral G cells. And 3. Histamine release through enterochromaffin-like cells. Gastrin and acetylcholine act through the phospholipase pathway, increasing intracellular calcium, whereas histamine acts through an adenyl cyclase pathway, increasing intracellular cyclic AMP. These pathways lead to the exchange of hydrogen for potassium on the luminal side and release of acid. Proton pump inhibitors like omeprazole act on this hydrogen-potassium pump, whereas H2 blockers such as famotidine act on the parietal cell histamine receptor. Gastrin release is activated by vagal stimulation, the presence of food in the stomach causing antral stretch, and peptides from amino acids of digested foods. Acid secretion from parietal cells is inhibited by somatostatin release from D cells, which are activated by low pH, thus completing the feedback loop. Risk factors for ulcer formation include H. pylori infection, NSAID use, smoking, steroid use, trauma, and Zollinger-Ellison syndrome. H. pylori can cause three types of infection: a diffuse gastritis, an antral predominant gastritis with increased gastrin and acid production with associated duodenal and prepyloric ulcers, and a rare atrophic gastritis associated with gastric cancer. The gold standard for diagnosis is mucosal biopsy during upper endoscopy. A urea breath test is a non-invasive test of choice for determining eradication of disease. Gastric ulcers are typically classified by location. Type 1 ulcers are located along the lesser curvature and associated with decreased mucosal protection. Type 2 ulcers are concomitant ulcers along the lesser curvature and duodenum and are associated with acid hypersecretion. Type 3 ulcers are prepyloric and also associated with hypersecretion. Type 4 ulcers are more proximal along the lesser curvature near the cardia and are associated with decreased mucosal protection, whereas type 5 ulcers are diffuse and associated with NSAID use. Ulcers along the lesser curvature are more likely to be benign, whereas ulcers along the greater curvature and larger ulcers are more likely to be malignant. There are three primary complications of long-standing peptic ulcer disease: acute hemorrhage, perforation, and gastric outlet obstruction. More in-depth coverage of treatment and management of ulcer disease will be discussed in Part 2.